When you're talking about basal ganglia, it is a misnomer. It should be better called as basal nuclei because you cannot have ganglia inside the brain. It's a misnomer. Now we have to talk about various nuclei under basal ganglia. Actually, according to Gray's Anatomy, there will be many nuclei under basal ganglia, but we will restrict ourselves to Ganong physiology. Ganong physiology will tell you only few nuclei which will follow. We are not following Gray's Anatomy here. Why? Because the examiner is not asking that much nuclei. So we'll restrict our knowledge. You should always limit yourself. It is equally important to know what not to know than to know what to know. Means you should know what is important and what is not important. You should know what is where to focus and where to defocus. So let us focus upon only important nuclei. See, there will be 3 structural and 2 functional nuclei given by Ganong physiology. I'll add one more. So there will be 4 structural nuclei we'll discuss and 2 functional. What is a structural functional? Structural means, basal ganglia is part of telencephalon, and if it is a part of telencephalon, then the nuclei in the telencephalon will be structural. But then there is some component from the diencephalon also, there is some component from the mesencephalon also, which are component of the basal ganglia, which is strange because if you say basal ganglia, it should restrict itself to telencephalon. But why are you including the component of diencephalon, mesencephalon here? Because they have some functional relation. So there are some functional nuclei which do not actually belong to telencephalon but are considered under basal ganglia. What is this about? Let's put the names and discuss the details. You see, we are going to make a flow chart now. 6 nuclei. So you want to discuss 6 nuclei in the basal ganglia. Yes, basal ganglia or basal nuclei, whatever you see, we want to discuss 6 nuclei. And out of 6 nuclei, how many you want to discuss as the structural? The 3 structural, and later I will add one more. What is structural? Means it is going to be part of telencephalon. And what is functional? Functional means they are not the part of telencephalon. So which nuclei you will consider under the structural component? Do you remember there was a comma-shaped nucleus, the caudate nucleus? So caudate is a comma-shaped nucleus, and then there is a putamen, and then there will be a globus pallidus also. So you are telling that there is a caudate nucleus, putamen nucleus, and globus pallidus, and they are under telencephalon in the adult brain. Yes, so they are structural component, and on the functional component I will tell you about subthalamic nucleus. If you are telling it is a subthalamic nucleus, then it must be a part of diencephalon. Yeah, because any thalamic nucleus is diencephalon. Then we will also include what is called as the substantia nigra. If you are talking about the substantia nigra, then I think it is mesencephalon. Yes, it is mesencephalon, but part of functional component of the basal ganglia. See, none of this is telencephalon, but they are under basal ganglia. Then what is the 6th nucleus? Because these are 5 only. You remember the caudate nucleus was a comma-shaped nucleus having a head anterior and tail anterior. Remember? Caudate nucleus became C-shaped nucleus, head anterior. Attaching to the tail anteriorly is the amygdaloid nucleus, and that amygdaloid nucleus is also a part of the basal ganglia. Now, understand, amygdaloid nucleus, which is attaching to the tail of the caudate nucleus anteriorly, which is a part of the basal ganglia. Is it a structural nucleus or functional? It is structural. Why it is a structural nucleus? Because it belongs to telencephalon. So, amygdaloid nucleus is a part of telencephalon. That's why it is a structural nucleus. So now you have 3 plus 1, 4 structural nuclei and 2 functional nuclei. Total 6 nuclei you are going to talk about now under basal ganglia by drawing some diagrams. But before you draw the diagrams, you should orient yourself to the diagrams, and let's do that. You are taking a transverse section of the brain now and looking from the superior view of the brain. So superior view of the brain means this will be the anterior aspect of the body, that is posterior aspect of the body. Yes. This will be the right side of the body. Yes, because if this is right, then this will be left side of the body, because you're looking from superior view, you know. So this is the diagram. Yes, transverse section. We have taken the transverse section looking from superior view of the brain. Yes. Like you are looking at a patient in the CT scan from superior view, and you have taken a CT scan and the nose is anterior. Though CT scans are viewed from inferior view, but we are looking from superior view here. That kind of view. Okay, then this is superior view of the brain. Yes, that view. And what do you want to see? This is the superior view of the brain. What I want you to understand is that there is the two thalami sandwiching the third ventricle in the midline. So these are the two thalami which are sandwiching the third ventricle in the midline. That third ventricle, yes, it is filled with CSF. Do you remember that? And then you will see there is the lens-shaped nucleus, which is lentiform nucleus. Lens-shaped nucleus, lentiform nucleus, part of basal ganglia. Yes. And then you will see the head of the caudate nucleus also. But before that, remember, lentiform nucleus has an inner globus pallidus and outer is putamen. So lentiform nucleus, there is an inner globus pallidus and outer is putamen. And then, as you have talked about the putamen, which is more lateral, you will say it is a part of lentiform nucleus. Look at the head of the caudate nucleus, which is more anterior. So these are right and left head of the caudate nuclei. Yes, more anterior. And once you have that kind of orientation, you will now look at the internal capsule. What is that? It is collection of axons, projection fiber from upper brain going to the lower brain, coming from the lower brain to the upper brain. They are projection fiber going up and down vertically, and they are U-shape, V-shape. Now when you're telling that it is the V-shape arrangement of the axon making some internal capsule, they have anterior limb and they have a posterior limb, and there's a bend called genu of internal capsule. Let us magnify it. We want to magnify it. And as you magnify, you will see the orientation now. Remember, anterior limb of internal capsule is sandwiched between. See, do you remember? Internal capsule is some projection fiber and dividing corpus striatum into two parts. And what was more lateral? Lentiform nucleus. What is more medial? Caudate nucleus. If you remember that, we have discussed in embryology that internal capsule is a projection fiber and dividing the corpus striatum in such way that lentiform is lateral and caudate is medial. Now understand, anterior limb of the internal capsule is sandwiched between. Anterior limb of internal capsule is sandwiched between the lentiform lateral and caudate medial, but the posterior limb of the internal capsule is sandwiched between the lentiform lateral again and the thalamus medial. So posterior limb of internal capsule sandwiched between lentiform lateral and thalamus medial. This orientation you should know. And let us proceed further. This is the diagram, which is the actual dissected specimen of the brain, and this is the corresponding part. Again, this is the internal capsule, V shape. You will have anterior limb, the bend is the genu, and the posterior limb, and this is the lentiform nucleus. There will be a head of caudate nucleus, and this will be thalamus. So all these details we have to discuss by drawing a diagram. But before you draw the diagram, let us look at these diagrams. You see, let me magnify it further. What you are looking at is right side of the brain now, right side, and you will find that this is the anterior limb and that is the posterior limb of the internal capsule. So if you say that is the anterior limb and the posterior limb of internal capsule, then what is lateral to that? Lateral to that is the lentiform nucleus, and which itself will have two parts. So you can see internal capsule, the anterior limb, and internal capsule, the posterior limb. I have shown with the red color. So you are telling, so it's better that I use the red color only, that will be better. This is internal capsule, the anterior limb, and internal capsule, the posterior limb. So the thing is, this is going to be the anterior limb and this is going to the posterior limb. And what is this structure here you have shown in green? That is the lentiform nucleus. And what about the lentiform nucleus? Actually, lentiform nucleus, we are telling there's a globus pallidus which is on the lateral side and medial side, and there's a putamen which is on the lateral side. So putamen will be lateral, yes, and globus pallidus will be medial. Yes, putamen is more lateral and the globus pallidus is more medial, and together they are forming the lentiform nucleus. Can I see that on the self-drawn diagram? Yeah, we'll do that. But at this moment, you have to look at some more details. What is the more details? Can you see that this is the two thalami? And if you say these are the two thalami, then what is this here? This is the third ventricle which is sandwiched between the two. So that is the third ventricle now. Yes. Actually, this is the third ventricle which is sandwiched between the two thalami. So this is left thalamus from superior view. Yes, this is right thalamus from superior view. Yes, sandwich between the two is third ventricle, which is a midline ventricle filled with the CSF. What is the posterior boundary? Posterior boundary of third ventricle. Yes, that was actually the pineal gland. If you say that is the pineal gland, this is the pineal gland. What was the anterior boundary? Anterior. Lamina terminalis, but also fornix. You remember fornix? Do you remember fornix? So understand, when you are talking about the third ventricle, midline ventricle, what was the posterior boundary? It was pineal gland and also posterior commissure, if you remember. So posterior boundary is pineal gland and the posterior commissure. I think anterior commissure was anterior. Yes. Anterior commissure was anterior. Fornix was actually roof of the third ventricle. Fornix is roof of third ventricle, but it also come anterior. So partly it is fornix, partly it is anterior commissure, and partly it was lamina terminalis also. And what is this? Connecting right brain, left brain. If this is right brain, left brain connecting structure, then you know what is the name of that structure, and we call it as corpus callosum. That is the corpus callosum. So you're telling this is right brain, left brain connector. This is corpus callosum. Commissure fibers? Yeah, commissure fibers. These are the commissure fibers connecting right and left brain, and these are the projection fibers. If you say these are the projection fibers, they are the internal capsule. Yes, I think this is the head of the caudate nucleus here. Yes, you can tell this is head of the caudate nucleus there. Head of the caudate nucleus there. So this is the head of the caudate nucleus. I believe that this is the anterior limb of the internal capsule. That is the anterior limb of the internal capsule which is sandwiched between the lentiform lateral and the head of the caudate nucleus medial. Yes. And there's the posterior limb of the internal capsule which is sandwiched between lentiform lateral and the thalamus medial. Yes, that is the point here. Now, once you have all that orientation, also remember some more details. See here, there is a optic radiation going towards the occipital visual cortex, which we have to draw in a diagram also. So this is going to be some optic radiation which is going towards the occipital visual cortex here. Yes, occipital visual cortex is there. This is optic radiation. And it will be passing through retrolentiform, part of the internal capsule. Now when you say optic radiation, optic pathway is passing through retrolentiform part of the internal capsule. Why do you say retro? Retro means behind. Behind what? Behind lentiform. So behind the lentiform you have some retrolentiform fibers of internal capsule carrying the optic pathway. Yes, it is called retrolentiform part of the internal capsule. This is what you have to remember. This is the midline of the body, and that is the anterior side of the patient, and this is the right side of the patient. You mean to say you are looking from the superior view of the brain. Yes, this is superior view of the brain. And as you are looking at the superior view of the brain, you want to talk about the basal ganglia nuclei. Yes, this is the two thalami one on each side. If you say this is one thalamus on each side, fine. What is this ventricle sandwiched between the two? That is the third ventricle, and third ventricle is sandwiched between the two thalami filled with CSF. Then what is this nucleus which is anterolateral to thalamus? This nucleus which is anterior and lateral to thalamus is lentiform nucleus. It has two parts. There is inner globus pallidus and outer is putamen. So this is lens-shaped nucleus, lentiform nucleus, and which is having one inner part globus pallidus and outer is the putamen. Yes, and then you can also show what is called as the head of the caudate nucleus. That is head of the caudate nucleus more anteriorly. Now, once you have shown the head of the caudate nucleus more anteriorly, understand the caudate nucleus and the putamen and the globus pallidus are the three structural component of the basal ganglia. If you say caudate, putamen and globus pallidus are the three structural component of basal ganglia, you also found some lines between the caudate and putamen, some gray matter lines. As there are some gray matter lines between caudate and putamen, it is called as the striatum, and when you say striatum, it means it is putamen plus the caudate nucleus. And what is putamen plus globus pallidus then? Then it was lentiform nucleus. You mean to say putamen belongs to two places. If you say putamen plus caudate, then it is called striatum. But if you say putamen plus globus pallidus, then it is called as lentiform nucleus. These are all MCQs. Understand? Putamen is at both places. If you say putamen plus caudate, some gray matter lines they are seen, striatums, lines, striations. And if you say putamen plus globus pallidus, then it is already mentioned lentiform nucleus. Now, you have to talk about the functional nuclei. As you're talking about the functional nuclei, you will see there is one under the thalamus, so we will call it as the subthalamic nucleus. This is the subthalamic nucleus under the thalamus. So this is subthalamic nucleus under the thalamus. There is one more which is called as the substantia nigra. Here is the substantia nigra. See, substantia nigra is a part of the midbrain but is a functional nucleus of basal ganglia. The subthalamic nucleus is diencephalon but is a functional nucleus of the basal ganglia. There are two functional nuclei we have seen now, and remember, substantia nigra is dark color. Why substantia nigra is dark color? It is dark color because of the deposition of melanin. So there is some deposition of melanin and making it dark color. Yes, that is substantia nigra. It is making dopamine now, and that dopamine is important in a pathway which is here. What is this pathway you are talking about? Actually, substantia nigra is a functional nucleus of the basal ganglia, and it is dark color, having some melanin deposition, and is making some dopamine neurotransmitter is important for this pathway. What is this pathway? This pathway is called nigrostriatal pathway. The name is suggesting it is coming from substantia nigra to the striatum. So coming from substantia nigra to the striatum is the nigrostriatal pathway, and it requires dopamine. Some patients have less of dopamine, resulting in Parkinson's disease. And when there is a Parkinson's disease due to deficiency of the dopamine, this pathway was compromised. Which pathway was compromised? The nigrostriatal pathway. So nigrostriatal pathway is compromised in patients of Parkinson's disease because they have the deficiency of dopamine. Yes, and since there is deficiency of dopamine, there is a relative increase of acetylcholine. And what are the clinical features then? The clinical features are tremors, like pill rolling tremor, and there is rigidity. Which type of rigidity could be? Cogwheel, or it could be, lead pipe rigidity. So you are telling that this is a case of some Parkinson's disease. Yes. What is that? There is some deficiency of dopamine and relative increase in acetylcholine, resulting in tremors. What kind of tremors? Pill rolling tremors. And rigidity. Which kind of rigidity? Cogwheel type of rigidity. Lead pipe So it could be cogwheel type of rigidity or lead pipe rigidity. And what else is there? There's hypokinesia. What is hypokinesia? Kinesia means movement, less movement. So there is less movement. Yes, hypokinesia, less movement. Okay, what do you do now? What I do, I will feed the patient dopamine. Which dopamine you will feed? I'll give the patient number 1 L-Dopa to increase the level of dopamine. I'll also give anticholinergic. Can you tell some anticholinergic? Yeah, trihexyphenidyl. What is trihexyphenidyl? It is anticholinergic. So treating your patient with L-Dopa to increase the level of dopamine? Yes. And you are giving trihexyphenidyl, which is some anticholinergic, to take care of this thing here? Yes. Because these patients are having some tremor rigidity, it will take care of that. But you have not told what is the function of basal ganglia. First, you should have told what is the function of basal ganglia. Yeah, function. Let us discuss the function also. So, when you're talking about the function of basal ganglia, remember, basal ganglia is for planning and programming of voluntary motor activity. What is the function of basal ganglia? The function of basal ganglia is planning and programming of voluntary motor activity. Actually, understand that voluntary motor activity is done by pyramidal system, but it must be planned by extrapyramidal system. So, basal ganglia is extrapyramidal system. Yes, it is. See, understand. It is a pyramidal system which is carrying out the voluntary motor activity, but before the pyramidal system carry out the voluntary motor activity, it must be planned. And who is planning? That is done by the basal ganglia. It is extrapyramidal system. Can you demonstrate some task to describe what is basal ganglia for? Let us leave this diagram for the time being. We'll come back to this diagram again, but at this moment, just look at this. What? You have given a task to the patient, put a thread into needle, thread a needle. So, who is threading the needle? That is pyramidal system. It is pyramidal system which will help us to thread the needle. But pyramidal system cannot thread a needle until you plan and program by basal ganglia. So, what the basal ganglia is doing? You have given the thread and needle to the patient on a table and asking the patient, look at the table, you have thread and needle, take the thread and put into needle. The patient will come to the table and for a brief moment of time, he will think using basal ganglia. The needle is very small, the thread is very small, I have to keep the needle in my, see, he's doing nothing, he's just thinking. I have to take the needle in my left hand and the thread in my right hand so that I will put the thread because my right hand is more, dexterity is more, I am a right-handed person. Are you doing anything? No, I'm just thinking. What are you thinking? Needle is small, thread is small, and I should take this needle in my left hand, thread should be in my right hand. Who is doing all that? That is basal ganglia. And then what will happen? See, it is taking very less time, picoseconds, and the patient will just see and take and do the movement. Who is doing the movement? That is pyramidal system. But before that, basal ganglia has already worked. And what if it is not working? If it is not working, there will be extrapyramidal symptomology. What is extrapyramidal symptomology? Under the extrapyramidal symptomology, there could be tremors. What is tremors? It is a purposeless involuntary movement. Purposeless involuntary movement. So, you're telling that if there are basal ganglia lesions, there will be extrapyramidal symptomology like tremor. Tremor is a purposeless involuntary movement. Do you have a purpose for a tremor? No. Can you control a tremor? No. So, it is a purposeless involuntary movement. What other purposeless involuntary movement could be there? Chorea. What else could be there? Athetosis. What else? Balismus. So, you are telling that these are all some purposeless involuntary movements. PIMS? Yeah, PIMS. You can say PIMS. Maybe tremors or rigidity, chorea, athetosis, balismus, like you will find. Lesion of subthalamic nucleus leads to hemibalismus. Hemibalismus. So, you're telling that there is some lesion in subthalamic nucleus lead to hemibalismus? Yes. What is hemibalismus? It is some purposeless involuntary movement. Purposeless involuntary movement. And what if lentiform is damaged? Lentiform damage, like in Wilson's disease, there can be happening Wilson's disease, there is a problem of the lentiform nucleus, and there will be again some purposeless involuntary movement. So Wilson's disease will compromise lentiform nucleus, leading to some purposeless involuntary movements. Yes, these are all extrapyramidal symptomologies. That you remember. Now, once you are through that all, as you have already discussed basal ganglia extrapyramidal symptomology also, you have to talk about pyramidal system then. And pyramidal system is for fine and skilled voluntary motor activity, like putting a thread into needle. If you want to put a thread into needle, that is pyramidal system. And if you want to plan about it, that was extrapyramidal system. Planning is by extrapyramidal system. Okay. This is the patient with Parkinson's. Tell me the clinical features. Clinical features are, there is a mask-like facies, paucity of movement. Paucity, hypokinesia is also there. So there will be a slow and shuffling gait. Actually, they find difficulty to start the movement and difficulty to stop the movement. First of all, they cannot start the movement, and once they start the movement, they find difficulty stopping the movement. So starting and stopping the movement is a problem, and there is some mask-like facies. Pill-rolling tremor we already told, and there could be cogwheel rigidity, and there could be lead pipe rigidity also. These are all features of Parkinson's disease. There is less of dopamine, so give the L-dopa, and there is more of acetylcholine, so give anticholinergics, trihexyphenidyl like drugs.